Well, you heard Jan mention it, semaglutide. It's a weight loss drug and it's been called a new era in tackling obesity. And we know excess weight increases the risk of type 2 diabetes, heart disease and some cancers. And at the same time, the usual medical mantra of diet and exercise has failed to turn the tide. By 2035, half the world's population, yes, half, is projected to be either overweight or obese. And against that backdrop, a seemingly simple jab that sheds the pounds is making huge waves.
Game-changing weight loss drug to be made available on the NHS.
Hollywood's worst kept secret is coming to a pharmacy near you.
Maker of fat loss drug says shortages will be fixed.
Those are just some of the recent headlines about semaglutide. You might know it by its brand names, though, Ozempic and Wegovy. Now, today, we're assessing what they can do, whether they can work, and why some doctors think this drug is about as controversial as they come. It's important because semaglutide is not just some promising drug on the distant horizon, it's already here. There's so much to unpick, and it's a topic that, let's be honest, reflects back on our own opinions about obesity as well as society's failings. So who better to kick us off than our resident GP, Dr. Margaret McCartney. Margaret, so thanks for coming in.
Thank you for having me, James.
So have you been following as closely as I have all the headlines around Hollywood's little secret, the skinny jab?
Yeah, well, we clearly read different types of newspapers there.
I have to read all of them.
But yeah, I mean, the hype about these new drugs is astonishing.
I've seen so many pictures of supposed transformations.
Yeah, and I think that there's a huge expectation and pressure. There's waiting lists I'm seeing on online pharmacies all over the place.
Well, this is the thing, isn't it? I mean, kind of we've had Boots High Street chemists announcing that later in the year you're going to be able to walk into there and be able to get it after a consultation. You've got people in private clinics selling it, National Health Services considering whether it should give it to people to help with weight loss. I mean, there's a lot to digest.
There certainly is. And when I was looking through various private clinics' websites, some of them are saying things like, we've just managed to obtain a supply, so there definitely are shortages. And we certainly got letters through the post at my GP surgery saying that there were shortages.
So just remind me, what exactly is this drug?
Okay, so I think it's probably better if we talk about a family of drugs that have been used up till now for people with type 2 diabetes and who have issues within that, their conditions not being well controlled on the medication they're already on. So we are using some of these drugs just now in NHS practice under specific circumstances. But what's happening is the reach of these drugs has been broadened to include treatment for people who want to lose weight or who are obese. And this is new, this is different, because when it's been used in type 2 diabetes, a side effect of it has been weight loss. But this would mean using these medications specifically for weight loss in people whose condition is obesity.
We're going to unpick it all, but how controversial do you think this is as a discussion?
Maximum, I think it's 10 out of 10, James.
Well, Margaret, stick around because we're going to chat to Jan, who's taken the drug, in a minute. But first, we've been on the streets of Cardiff to ask, would you take it?
Definitely. As you're getting older, the weight starts to affect everything else, like your bones and everything.
Same.
Like your knees and your feet and legs start hurting.
25 years ago, I could run.
Yeah, even with
I can't run now.
The extra weight.
Especially my job, sitting down all day. I'm a bus driver. You tend to eat a lot of rubbish. You're sat down in the same position, so you're not getting no exercise. And then the weight's piling on. Eating late at night as well. It doesn't help.
He's at the house 14 hours a day. Some days I could be doing a 16-hour shift. Last thing I want after that is a gym. I need my bed.
I would never ever consider taking it. It's too dangerous.
If I was obese and the NHS recommended it, I may consider it.
No, I wouldn't be interested in taking a drug that did that. I'd rather manage it myself, thank you.
Seeing something so easily accessible as just being able to lose weight to look like, I don't know, like Kim Kardashian or whoever it is that you want to look like is quite worrying.
How much testing have they done on people who are obese, and are they still okay? Are they going to be okay in 5-10 years?
Well, it's a good question, isn't it? Fortunately, we can turn now to Jan, who we heard from right at the beginning of the programme. She was on those trials of semaglutide, having injections every week for 15 months, that given alongside dietary and exercise advice. And over the 2,000 or so people that took part, on average, people lost 15 kilograms over that time while they were taking the drug. If you're still in pounds and stone, that's about 2 stones worth of weight loss. So we can chat now to Jan. Hello.
Hi, hello. It's lovely to be here.
So you're one of the few people in the world that has actually taken this drug, semaglutide, for a little while, aren't you?
I have spent my whole life dieting, basically. I would lose weight. I'd then put it back on. I'd start another diet. I did all the sort of commercial ones with the groups, even down to when I was 6 years old, I was on a diet trial in a hospital.
That must be quite a burden to carry your whole life. And I don't mean that literally, I mean just psychologically.
Yes. I mean, for I think it was 12 weeks, I was inside a paediatrics ward being sort of, my food was monitored, I was being exercised, and it was all looking at if you can stop a child being obese, then you stop the adult being obese. So yes, from age 6, basically, I've had a weight problem. I mean, at school I was very active. I was just big and active. So like I was in the netball team, I was a house captain. So it didn't hold me back, but it was something that I battled with constantly.
And let's fast forward in time. When did you get involved in the trial?
It sounded really good. So I was very enthusiastic, and it was a blind study. So it could be that I wouldn't get the medication, but it was also the whole approach to lifestyle, exercise, nutrition, and went and joined the trial. Unfortunately, I got the medication, the semaglutide.
So it was weekly injections. Was it working?
Basically, I knew within a few weeks that I was on the medication because I started changing around food. Like I'd go into a coffee shop and I'd order a coffee and I wouldn't be staring at the muffins and the millionaire's shortbread and thinking, I need one. I could actually look at them and think, that looks nice. I don't want one. I don't feel hungry, which was a miracle, basically.
Was that the first time in your life that it had been like that?
Yes, totally. It was my body was saying, you don't want it. It wasn't me using willpower thinking, I can't have it. It's not good for me. Or I've had my 600 calories today. I can't have that because it's another 1,000 calories, or it's 6 points, or it's a yellow, or whatever. I went back for my appointment with UCLH, and they were like, oh, no, we can't say whether you're on it. We don't know even who's on it. So my comment was, well, I'm on it, or I've been abducted by aliens because I have completely changed. After 62 years of life, I've completely changed around food.
It allowed you to do things that you wouldn't have been able to do before.
Yes, the classic being the flight.
I'm Stephen O'Reilly, and I'm Director of the Medical Research Council's Metabolic Diseases Unit at the University of Cambridge.
Stephen, welcome to Inside Health.
Hello.
These drugs, how do they work? What is it that they're doing inside our bodies?
Well, they mimic a natural signal, and there are two sorts of natural signals that our body gets to help us understand what our nutritional situation is. And one is the long-term signals that come from our fat cells, and the others are shorter-term signals that come from our gut and come from our pancreas. And they're hormonal signals, i.e. they're little small molecules that float in the blood and are made by the gut and made by the pancreas and go to the brain and actually keep the brain informed about what you've just eaten and how much you've eaten. Now, what these drugs do is that they dial into this system and they actually soup it up to supranormal levels. And so the nice thing about them is they're quite safe because they're actually acting on normal systems. They're just turning the volume up to max.
So are they working on what the gut's doing or what the long-term fat stores are doing?
Well, what they're really working on is your appetite. And they're working on the bit of your brain that senses when you're hungry or satiated. And they're changing that electrical signaling in the brain to make you feel less full. And it really is pretty much as simple as that. I mean, there's no magic metabolic effects of these drugs. They only work by changing what you eat. They really do work quite powerfully on that. They make people much less hungry. They make meal sizes much smaller. And if you dial the dose right, if you overdo it, you get nausea and sometimes vomiting and diarrhea. But principally, these drugs are dialing in to human appetite.
And do things start to balance out over time? Because we know how the human body responds. Kind of like if fat reserves start to disappear, then that sets off a whole other load of hormones. Kind of like, do you get a bit of a tussle between the drug and the rest of the body screaming, no, I'm actually losing weight here?
Yeah, indeed you do. And that's been what's stymied many, many dietary interventions. Lots of people can lose weight when they decide to go on a diet. And they do so really well and they can be helped by professionals and they get their weight down. But the depressing thing about many of the studies are that after 2 years, those pressures that the body's put on to put the weight back are immense, and more than 90% of people tend to end up back at the weight they were before they started on their dietary journey. The thing about these drugs is that we know so far about them being prescribed for over a year and a year and a half. As long as you keep taking them, the weight stays off.
Well, so far on this Inside Health special on semaglutide, we've heard what the drug is doing inside the body and the undeniable, quite frankly, evidence that while you're taking it, the weight comes off. But Margaret McCartney, you're still here with me in the studio. The real issue is what happens when you stop taking the drug.
This is the big problem. So the trials up till now have shown benefits for many people who are taking it at the time, this weekly subcutaneous injection. And it definitely is a real effect. There's no question about it. But then when you stop it, many people put that weight that they lost back on again. So the problem is then this becomes a drug that's not just taken to lose weight and keep the weight off. It's a drug that seems to need to be kept taken in the longer term in order to ensure that weight doesn't return back again. And that's, for me, a big problem.
Is there a health benefit, though, in losing weight, even if it's just for that short window of time while you're taking the drug? Does that leave a lasting benefit, or is it only while you're losing the weight?
You could see that perhaps if you had, say, a hip replacement that needed to get done and you were out with the weight criteria that the NHS puts on you, you can see how that might work for you, that you might just want to, even a temporary weight loss might be something.
Some fertility treatments have weight categories.
You can see how that might be something that's appealing to some people, even if they know that the chances are the weight will go back on when they stop it. But in terms of the risk factors and so forth, blood pressure, lipids, etc., these seem to return back to where you were to start off with once you've stopped taking it for that group of people that seem to put the weight back on again, unfortunately. So there does seem to be a benefit, but the benefit is mainly there when you're using the drug. The problem is what's going to happen next.
I lost 28 kilograms, which is roughly about 4 stone.
Let's fast forward a little bit further. The trial ends. You stop getting the semaglutide.
Even though I was promising the world to anybody who would give it to me.
Was that tough?
In a way, yes. I was quite upset because the weight was going back on and I had started looking at food again.
I was going to say, were you back in the coffee shop? You've got your coffee and now the muffins are calling.
They were calling more because those sensations, those feelings were returning. And to me, it was going in the wrong direction again.
And then there was a decision to have an operation, wasn't there, to have a gastric sleeve?
Gastric sleeve, because that would then increase my natural gut hormone production. And by the fact that they would reduce half the stomach, it would mean that I would have a lot less space to eat.
So you'd feel fuller, faster again?
Yes.
So Jan, no regrets?
Absolutely none whatsoever. It's the best thing that ever happened to me.
Jan's a happy customer. Well, the NHS does already prescribe semaglutide for some cases of type 2 diabetes. That's under the brand name of Ozempic. So what about purely for weight loss? Is that something the NHS should be doing? This time you need a higher dose of semaglutide, and that's marketed as Wegovy. I'm sorry, there's so many different names, but you've probably heard a random mix of them in the news. Now, all the evidence has been considered by the National Institutes of Health and Care Excellence, and that gives its advice to the NHS in England, Wales and Northern Ireland. But they're not considering semaglutide for anyone and everyone. They're only considering it for people with high body mass indexes who need specialist services by the NHS weight loss clinics. And they're not looking at giving it forever, only for a maximum of 2 years. We've already heard how weight goes back up once you stop. So there's been criticism that obesity is not being seen as a lifelong condition. And there have even been warnings that being forced to stop after 2 years could cause psychological harm. So back on the streets of Cardiff, is this something our taxes should be spent on?
Yeah, I think it should be available through the National Health Service because financially it would help everybody.
I'd much rather see more education from school time upwards, healthy eating, being able to cook properly, etc., etc.
I don't think it should be made available to anybody because you will get people that might not necessarily need to lose weight but would take it anyway.
I think as long as it's prescribed by a doctor and not something that I could just order myself on Instagram because I'm feeling particularly self-conscious today, then I think that that's a good thing.
So Margaret, the big discussion in the UK in terms of NHS provision has been around whether people should have it for basically around about 2 years. Is that moral? to do it for that length of time. Do you know what I mean? Because like if you're basically saying that you might lose weight for 2 years, then it's all going to come back on and everything reverts back to normal. So I'm almost like going, what's the point?
Yeah. So certainly not everybody will gain the weight back on again, but a majority of people will. And I completely get that, because it's kind of a bit unfair, I think, in some ways, because people particularly that I think are using this treatment are people that have tried pretty much everything else. It's not their fault. We know there's a huge amount of weight stigma goes on. There's a huge amount of blame and shame attached to it. I mean, it's really pretty awful for many people who are wanting to lose the weight and have struggled usually for years and years and years. And if you get something that ends up working for you, and you've gone through the treatment pathway, you've complied, because it's not just about the injection. You still have to follow, diet and exercise guidance. You're meant to have a calorie deficit every day. You're meant to be doing more exercise. It's a big commitment. And then for the NHS to go and withdraw that again, it does seem to me to be a bit unfair then to leave people at the end of it. And I do worry that if the NHS calls a halt to funding, then only people that can afford it may end up getting it privately. And what makes me really upset about this is we know that there is a very clear deprivation quality to this, that deprivation is a real risk factor for obesity. So we're talking about the most vulnerable people in our society already.
This begs the question, if you need to stay on the drug for basically forever in order to keep the weight off, do we know what happens when people stay on it for a very long time?
So we absolutely don't. It's a new drug. We don't have that very long-term data. And in my view, everyone that's on it longer term like that should really be in a trial. They should be followed up so that we know exactly what's going on and also what's not going on. Because many of these people, will end up, I think, taking it for years and years and years.
Do we not get a clue from people with type 2 diabetes who are being prescribed it for that? They must be on it for a longer time. We must have seen some of that data.
Yeah, but again, I think it's a different set of circumstances perhaps from weight loss. And certainly, that there are concerns, about rare side effects. For example, it does increase the risk of gallstones, for example. In animal studies, they've detected, and it's not human studies, but in animal studies, they've detected an increased risk of thyroid cancer, for example. We also know things like it can produce a decrease in muscle mass in some people, which again is important because muscle is useful as you're getting older in particular. So, all these things, they have to be looked at really carefully.
I am Naveed Sattar. I'm Professor of Metabolic Medicine at the University of Glasgow.
Naveed, welcome so much to Inside Health.
No, thank you. There are still some uncertainties. So there are a number of ongoing trials which are looking at the safety of the drugs prescribed at higher doses that cause sufficient weight loss in terms of, are there any other hidden signals of harm that we didn't know about? So those trials are going to start to report out towards the end of this year, next year, the following year. So in about 2-3 years' time, once that data comes forward, I think that will spur on the even wider usage of these drugs beyond weight loss. The other big issue, of course, with these drugs, they're very expensive. Now, clearly, the NHS cannot afford to be giving this drug to millions because we simply can't afford it. So over the next few years, I think some of these things will resolve. We'll have better trial evidence about safety, and I think hopefully the cost will come down, and then we will gradually start using these drugs in more and more people is probably the vision that most people see.
Naveed, I can't quite figure out in my head whether it's something to celebrate that medicine has produced a drug that can help people lose weight, at least while they're still taking it, or if it's actually the opposite, that we've tried and failed so badly to tackle obesity throughout society that we now need to start turning to drugs.
I think that's a brilliant point, and I think many of us have been wrestling with that. I mean, to be honest with you, I would love it if we had a society where we did not have an obesogenic environment, we did not have so many dense calories easily obtainable at cheap cost all over the place. I would love that. I would also love if more people were able to walk to work, cycle to work, have more activity and enjoy that. But we don't. By 2035, half the world's population is going to be overweight. So it's a reality of industrialization, of cheap sugar, cheap fat, putting in lots of calories all over the world. And that has fed into human biology of being tempted by food and overeating. And that's a problem because effectively, the NHS is a bit of a shit show at the moment. Many of our patients have 4 or 5 conditions as a result of their excess weight. And yet, at the moment, we pay lip service to it. We treat the downstream disease and we don't treat the obesity. And that's a big, big problem. So as the cost of these drugs come down, we should be using them in more and more patients.
Naveed, it sounds to me like you want a lot of people on these drugs for a long time.
No, I don't. No, I don't want individuals to be on these drugs for a long time. But what we should be doing, and it's a paper we wrote in The Lancet with some world leaders, is that we should be looking at the evidence base of tackling weight, both by lifestyle and by some of these drugs, earlier in the course of many diseases, I mean, even at the start of diagnosis of some of these conditions, can we prevent that individual developing their second, third, and fourth or fifth condition, many of which are currently linked to excess weight, to almost change the paradigm and prevent many developing multiple conditions at the same time?
Naveed Sattar there. Now, what we've been talking about so far is the health impacts of obesity and whether the NHS should pay for semaglutide. But there is another dimension to the story, because if you've got the money, you can just go buy it. The drug's available in private clinics and high street pharmacies, often needing only an online consultation. Now, how this collides with celebrity culture and ideals around beauty also raises issues, doesn't it, Margaret?
I think that medicine as a profession should be particularly humble when it comes to the issue of weight, because medicine has a long and very dirty history when it comes to promoting treatments for weight loss that just simply do not work at best, or are actively harmful. I don't think we've really covered ourselves in glory. There have been drug after drug that's been licensed, put out into the world. We've been told that that'll help you lose weight and then has been withdrawn. So I think we have to be really careful, because there's a huge pressure from society on medicine to come up with some kind of solution to this. If we're thinking about the obesogenic environment that we're all said to live in, shouldn't that be worthy of better exploration, rather than expecting individual people to first of all become obese through their environment and then to accept a medical intervention to treat it?
What's the difference? Let me be controversial. What's the difference between this then than something like a statin or a blood pressure medication, which are again often, a symptom of lifestyle?
Yeah, so it's different because obesity is such a stigmatised condition, I think, and it's such a visible condition. So many people have many risk factors that they manage to keep quite quiet about that most people won't know. But because obesity is visible, I think it makes it much more difficult for somebody to exist well in society when there's so much obesity bias and stigma about.
And then you've got a layer on top of that, Margaret, the celebrity culture that seems to have come with it. Huge number of celebrities loving the amount of weight loss they've had. Then you've got all the ones that have had remarkable amounts of weight loss. And then you're sat there kind of going, have they been taking that? Have they been taking the drug as well? I mean, it's really thrown weight loss into like the A-list celebrity world, hasn't it?
Yeah. And again, it's a real shame because there's not that element of privacy, I suppose, for many people that are perhaps thinking about using this drug or are using that drug. And I think that's, again, it feeds into the stigma about obesity as well. But I think the other problem is that we're not talking really about health a lot of the time here. We're talking about aesthetics.
Appearance.
Yeah, we're talking about the way that we look. And that's not healthy. And, I know that there are many people who are carrying excess weight who do feel as though their life is impaired because of it. And, I want them to get the best possible treatment. But also, I don't want young people to be thinking that they should use something like this in order to look in what they would consider to be a better way, because society is the problem. It's not them. So really we have to be very careful whose problem it is that we're treating.
Yeah, one of the things that I'm kind of worried about with all the discussion around this is whether it suddenly drives up cases of eating disorders.
Yeah, I think you're absolutely right to be concerned about that. And I really do worry about the vulnerable people in society who will see this and they will think, well, there's another way that I could try and make myself look thinner. So, I think when it's rolled out into a drug for purchase, something that's just on your shopping list, quite literally, I do really worry that this then becomes a societal issue. There are big moral and ethical issues in there.
Margaret, I've got a little bit of an article that I'm going to read to you. It might increase your blood pressure, but I just want your reaction to it anyway. Is this a cure for obesity?
I honestly wonder about the sanity of our media that are promoting that kind of message. It's clearly not a cure for obesity.
Margaret, thank you so much for coming into the studio today. There are just so many issues and ethical dilemmas around this drug, aren't there? And I think we're all going to have to tackle them as a society. And it's going to get even bigger because today we've been talking about semaglutide and the way it tricks the brain into thinking we're full. But there are more weight loss drugs on the horizon. Here's Professor Stephen O'Reilly on where he thinks we're heading.
I see it as the beginning of an exciting era where we can really help people who have struggled for a long time. And we're not talking about cosmetic, we're talking about the serious health implications of being obese. And reducing those are really what those of us who work in the area have been interested in doing.
Stephen, I'm curious, is semaglutide the one, or is it more symbolic in showing that a weight loss drug is possible?
I think it is, in inverted commas, a breakthrough, although there are others coming, and very soon there'll be a posse of these agents competing with each other for prescribing. And I think there were many naysayers who said it wasn't possible. Drug development for obesity has been very challenging. There have been effective drugs, but have been dangerous. and there have been safe drugs that haven't worked. Now we have a pretty safe drug that looks like it works. And if we take blood pressure as an analogy, we now have much better outcomes with people with very high blood pressure than we ever had before. And we have that largely because we can use 2-3 different types of drug agent which work in different ways and get everyone's blood pressure down so they don't have strokes and they don't have heart attacks. So that's our main aim, is to stop people having awful side effects of their obesity. And if we can do that effectively and safely, I'm very excited by the possibilities.
Just paint me your vision of the future, Stephen. Where are we going to be in 20 to 30 years' time, do you think?
I really hope we do 2 things. We need to improve our obesogenic environment for all sorts of health reasons, but not only obesity, to prevent obesity happening. But there will be obese people, and they will become ill unless we treat them appropriately. And I think that in 10, 20 years' time, carefully and treating obesity properly as a medical condition, we will be able to improve people's longevity and their lives and their health.
It's life-changing, and I feel it should be available on the NHS to people who have battled with their weight for years, people who say need to lose weight because they need to have an operation and their BMI is too high. Also, it should be for people who can't afford to buy it as well, but it needs to be done properly. I was monitored. I had nutritionists that I spoke to regularly. I had people who would help me with the exercise program and what I was doing and steps and things like that. And also there was the medical side of checking for side effects, doing blood pressure, monitoring the whole person. That's what made a success, having the whole package, the wraparound package, not just once a week stabbing myself with an injection.
Jan, thanks so much for coming on and sharing your experience.
You're welcome, and hopefully this will help a lot of other people out there.
Well, what do you think? Is a weight loss jab necessary or a sign that we've given up making our lives and society healthier? Who should get it? And for how long? I mean, it is a surprisingly complicated subject, isn't it? I'd love to hear your thoughts. insidehealth@bbc.co.uk is the email address. Thank you for listening to the Inside Health podcast with me, James Gallagher, and thanks to producer Erica Wright and studio manager Sarah Hockley. See you next time.